This is chapter 6. I broke it into 3 lectures, 2 of which we'll do today, one of which I don't have, which is on retinal vascular disease and cardiovascular disease. It's a funny way to group it. Oh, thanks. Oh, thank you. It's a funny way to group it because I've never heard it done this way, but it's just a way to divide up the curriculum. I would just call them retinal vascular disease. So, oh goodness, I'm never going to be able to see it. So this is, the first one's hypertensive retinopathy, which is going to cover hypertensive retinopathy, choroidopathy, optic neuropathy, and arterial macroaneurysms. And is that okay? Can you still see me?
Oh, no.
You don't see me. Now you got to leave it on. The pictures aren't that moving for this. So first of all, this always drives me crazy, an artery versus an arterial, because people will sometimes say the central retinal artery, branch retinal artery occlusion. Some will say, no, it's an arterial, it's not an artery, so it's an arteriolar occlusion. So there's a difference between arteries and arterioles, and this is what ophthalmologists need to know. Arterioles have an internal elastic lamina and 1 or 2 layers of smooth muscle. They don't have an external elastic lamina, and that's where you get atherosclerosis. So this picture's an artery, and you can see the external elastic lamina, and that's what the arterioles do not have. They work to they constrict and loosen to help protect the small capillaries, and they're less than 100 to 300 microns in diameter. So it's probable the central retinal arteries is probably an artery, but the branch arteries maybe start as arteries, but then they turn into arterioles. Just so you know that. So hypertensive retinopathy. First of all, you need to know a little bit about autoregulation. Precapillary arterioles have those muscles on them so they constrict or dilate in response to 2 things. One is ocular perfusion pressure, so they try to protect the capillaries if the perfusion pressure's too low, they open. If it's too high, they close a little bit. And the other thing is they'll open and close based on metabolic demand. So, and we talk about that a lot in conference based on oxygenation. So if you see the vessels constricted, it sometimes means they're in a high oxygen environment, which is why in retinitis pigmentosa, your arterioles are thin because the oxygen of the choroid is making them thin. So they're sitting in a high oxygen environment. There's no neuronal innervation of retinal vessels. The choroidal vessels have innervation, but the retinal vessels don't. Hypertensive retinopathy is complex. So a lot of it has to do with duration of the hypertensive, dyslipidemia, age, and smoking. I can't imagine that lady had hypertensive retinopathy when I saw her, but go ahead.
Sorry, just get back to the RP.
Oh, yeah.
Well, why is it that they have a bunch of oxygen?
Oh, because the outer retina is dead. So that's the biggest consumer of oxygen is your photoreceptors. Your outer retina consumes an enormous amount of oxygen.
Okay.
So in retinitis pigmentosa, the outer retina is dead. So all that tissue is not using oxygen, and the choriocapillaris is pushing all the oxygen through. Okay. So the retinal vessels are existing in a relatively high oxygen environment, so they constrict.
Okay.
And if it's and that's the other reason in diabetics you'll see them sometimes enlarge a little bit, probably because
Does that have anything to do with like the waxy appearance of the disc?
No, that's because the cells are dead. That's
okay.
good. And then and then the other thing, again, from your BSCS book, which I can't imagine they put this on the boards, but I never trust anybody. It says focal arterial narrowing and AV nicking have little predictive effect for actual hypertensive. So even though we look at AV nicking and say, oh, your blood pressure is probably high, apparently in the real world that's not actually true. So if I were a board examiner, I would stick that on the boards because it isn't in the textbook. So arterial narrowing has to do with arteriosclerosis. You cannot get atherosclerosis in retinal vessels, but you can get arteriosclerosis, which is an increase in the elastic and muscular component of the vessels. So the muscle layers get replaced by collagen, and the light reflex changes some. Atherosclerosis is when you get vessels in your larger arteries. You'll see copper wiring and silver wiring in a lot of articles and books and old textbooks. You don't see it much now, but I think it is in the Academy book. So when you see I could ask you, but it's up there. When you see a normal vessel, realize that you're looking at the blood column. So when we look at the retinal arteries and retinal veins on pictures, we're actually just looking at the blood column, if everything else, because everything's transparent, which is remarkable when you think that you can have a transparent tissue as complex as the retina. where the light goes through.
Yeah, and you can drive that home in surgery first years. When you just plant the conj, the vessel disappears, and then you see the blood column come back green.
Yeah, so you see the blood column. So you're looking at the blood column. Copper wiring is when the vessel narrows and you get a brownish or shiny brown reflex, which I don't know for sure I see. And I'll show you some pictures. Silver wiring is this, though. So when the vessel's white, it's silver wiring. And this is the fellow eye of it. But the other eye in this patient has central artery occlusion. This eye actually sees 20/30, and that's what the vessels look like, which is a glue. So silver wiring is when the vessel's white, if you ever see that. So there's 4 grades of hypertensive retinopathy. Grade 0 is normal. 1 is arterial narrowing. 2 is obvious narrowing with irregularities, which is the AV nicking. So grade 2 has AV nicking. Grade 3 is AV nicking with hemorrhage. Grade 4 is grade 3 plus disc swelling. So those are your 4 grades, which apparently are also, again, not that relative to actual hypertensive, except for 3 and 4, where you really got to check. So this is a patient. What do you think this one is? This is a patient where the arteries and veins look decent. You think that's grade 0, 1, 2, 3, or 4?
0. Like 0.
There's one leg there.
Yeah, that's hard. I think the diameters are okay. These, if you look at the veins and the arteries, they're pretty close to the same diameter. The arteries are supposed to be 2/3 the size of the veins. So I think this one's okay. So I called this 0. And this was a lady who came to see me for flashes, and her retinas were fine, and I took a picture for the lecture. And this is an older patient with equatorial drusen, and she's got the arteries, I think, are a little narrower, but the AV crossings don't look too bad. So what do you think this is? Also, we're likely going in order. So this is grade 1. So this is barely detect arterial narrowing. But if you look at the thing I'm going to say, if you look at the arteries, arterioles in these, that looks kind of coppery. So you'll see these reflexes really don't change that much. So as far as copper wiring, I'm not that keen on that. And I have to say, probably a decade ago, I saw a paper in JAMA where people were really pushing this, looking at retinal arteries to help with cardiovascular risk. I don't think they're helpful. And then this one has some AV nicking. If you look at the crossing like that crossing, that one not so much, but that one's definitely nicking the vein. So what's that AV nicking? What grade are we at? 2. So we did 0. 0 is normal, 1's a little bit of narrowing, 2 is AV nicking. I'll tell you the other thing for anybody who's going to go into retina or ophthalmology, or general ophthalmology, is I have this in my charts. So it's not almost everybody has some hypertensive retinopathy. If someone comes to see you for myopia or something, the 2 things I fall back on are drusen, because 90% of people have at least a druse, and most people have some arterial and narrowing. So I just appears in my chart. So insurance companies don't get upset.
I was familiar with the different staging. It may just be like a European thing. I'll see if I just made this up or misremembering. AV nicking 1, cotton wool spots 2, disc edema 3, macular star 4.
No.
Never heard of that?
Not in your book, anyway. Forget that one, because it won't get you past your boards.
Yeah.
That's what I do. When I prep these, I go through your book, because that's what you're supposed to know.
Yeah, you're right.
Because sometimes it conflicts with, and every once in a while I'm like, no, I don't agree. But this is, again, if someone's going to ask you a question, these are going to be there. Okay, so then what's this one? If you see some hemorrhages, pretend there's no optic nerve swelling. 3. So that's 3. So, and I don't know, I can't show you nerve scan on this one, so this is grade 3. And there's cotton wool spots and hemorrhages. These are bad. If you see cotton wool spots, here, I'll show you the last one. This is a guy that came in about a month ago to see me. 55-year-old guy, headaches, he was gregarious. I had to trim this HPI by about 2/3. There's so much in here. He had some nausea and vomiting. A few weeks ago, he had his left eye blurred. He had a headache. He does not have insurance, which is typical for this. The right eye's 20/20, left eye's 20/100. This is the right eye. And you can see the cotton wool spots. There's exudates over here. The nerve's swollen. There's hemorrhages. Everything's messy. And then this is the left eye with some more swelling. And then this is the OCT of the macula, and this is the OCT of the nerve. And you can see the nerves are swollen on both sides. So this is grade 4. So it's grade 3 plus disc swelling plus. And I have to tell you, this, I don't put it up here, this patient, I've had this all the time. If you see this eye, the differential for this eye is pretty narrow. It's not diabetic probably, because the guy, it just doesn't look like diabetic retinopathy really. there's not much other than hypertensive retinopathy for this
So
one.
that radiation.
Could be, yeah, really, no, because you don't really get cotton wool spots so much in radiation.
Diabetic papillitis?
What's that?
Would you consider diabetic papillitis?
Yeah, it could be diabetic papillitis and hypertensive, because diabetics really, we showed, Dr. Eichenbaum showed that one, there was no cotton wool spots in that pretty nasty diabetic he had. So cotton wool spots, this is hypertensive, so you gotta check the blood pressure yourself. And because this patient was sent to me having been checked at the referring doctor's office and in my office with a little bit elevated blood pressure but not high. I checked it and it was 250 over 170. When he got to the hospital, they got him at 280 over 170. And so in the machines just don't catch that. And do you know how to check for systolic, just to confirm your blood pressure monitor checking?
When you pump it up and you feel for the pulse
Right.
to reappear?
Yeah, so you feel for the pulse. So, and I do this on these. So you pump it up and you listen, but the sounds can be weird. So when I get one really high, I check the pulse, and then I try to get the pulse to disappear, and this guy was way high. And so I gave him a note, and he went right to the ER. I said, do you want to go by ambulance, or do you want to drive? And he had a ride, so he got a ride to the ER, and I told him which ER to go to. And he said he bypassed everybody. They put him right in the ICU. He said there's a big wait. He was really pleased. He said, I gave him your note. They took me right back, and within 10 minutes I was in an ICU bed. and he got monitored. And with very high blood pressure, they drop you 10% per day, so they keep you from crashing out, which I didn't know. I learned that from him. And he did well. The other thing with hypertensive retinopathy is your vision comes back. So he was 20/30, 2100. He came back to see me 2 days ago, I think. And this was the right eye, this was the left eye, still a little bit of fluid, and he was 20/20/20/32. So you got to check it yourself, and they really should go right in to the hospital. And he had his mother drive him, which was and this is what he looked like. I got pictures. So you can see there's still the cotton wool spots. The cotton wool spots fade in about 6 or 8 weeks. And it's nice to check. If you're unsure of a cotton wool spot, you got to check back for that, because it could be retinitis. This one I know is cotton wool spot, so I don't know if I booked him another appointment. And his vision came back, he should do well. And so that's hypertensive retinopathy. So hypertensive retinopathy is the cotton wool spots, hemorrhage, optic nerve. There's the 4 grades. 0's normal, 1's a little narrow, 2's AV nicking, 3's hemorrhage, 4 is when the optic nerve swells. And then hypertensive choroidopathy is a little bit different. Hypertensive choroidopathy is usually in young patients, acute hypertensive, like preeclampsia. Oh, this guy in the hospital, they didn't give me I said, what was it from? And he said, I don't know. They did a lot of tests. But then they didn't get, I said, was it renal hypertension or pheochromocytoma? And he said they did a bunch of stuff, and he's going to follow up, but they didn't really nail down a cause. He had lost half his kidneys, he had had a stroke, he was like a mess. So hypertensive choroidopathy, you get non-perfusion of the choriocapillaris. You can get Elschnig spots and Segrest streaks, which is these things you just have to know. And these dark spots are Elschnig spots. So they're little dark spots with a light halo, which are probably from, infarction of the choriocapillaris in one of the lobules. And it's one of these goofy things, and again, hypertension a lot of our presidents used to die of hypertension. Hypertension's not that big a deal right now, I don't think. But it's still, a lot of things take about 10 or 20 years to wash out of the textbooks. So there's still an enormous amount of stuff of hypertensive retinopathy. So Elschnig spots and Segrest streaks are in the periphery. And this is a 48-year-old patient, I think this might have been yours, Harry, who came in to see me years ago when she noticed a spot off to the side. No, it was more recent. Noticed a spot in the vision when she was blinking. Both eyes were normal, 2016, and the right eye 2020. This lady was 165 over 120, her blood pressure. And she had, this is weird, and I see this all the time. Her retinal vessels don't look good. I mean, that, again, if you're going to call copper wiring, I guess that would be copper wiring on top of that vessel. And you can almost see that that might be an atherometer right there. So the vessels are narrow, they're funny looking color, but she has a serous detachment, which you can see a little bit on the picture. The fluorescein shows a leaky spot near the nerve. It looks exactly like central serous, and that's the OCT. The one thing, if you see central serous with a normal thickness of the choroid, that's not bad choroid, get very nervous. And I still check blood pressure manually on most of my central serous patients. because it could be hypertensive. And the weird thing is they don't get the retinal signs. And I don't know. And I was talking to Aaron. I talked to Aaron. I said, we should write a paper. It'd be nice to try to figure that out because I've not seen a good paper on why some people present with hypertensive retinopathy and some present with hypertensive choroidopathy. They seem to be different. Like the other guy didn't really, well, I guess he did have some retinal detachment, but the choroidopathy patients can have no cotton wool spots and these subretinal fluid things, which is just weird. I think it might have to do with the systolic versus diastolic, maybe, but yeah.
Finding that atheroma, would you do anything about that?
No, not really. I mean, and again, most people are already being checked. I mean, if they never go to the doctor, you say, you got to get your lipids, blood pressure, lipid, all that. But, it used to be in the old days of ophthalmology, you'd see a pianist and send someone for cholesterol. Now, I've had my cholesterol checked. So, hypertensive retinopathies are retinal hemorrhages, reflections, nicking, cotton wool spots, optic nerve edema, and then you get this serous detachment for the choroidopathy, which looks just like central serous retinopathy. The next topic is arterial macroaneurysms. So, acquired ectasia in the first 3 orders of the retinal arterioles, okay, not in the periphery, like that choroidal one we saw before. So even though that's good to throw into the differential, if you have an exudative hemorrhagic peripheral lesion, it's likely not a hypertensive macroaneurysm. I guess it could be from Coates. They traverse the retina, and you can get vision loss from the obstruction of the vessel or from the hemorrhage. This is it's not up there. This is a classic hourglass hemorrhage. So if you see a subretinal hemorrhage, preretinal hemorrhage around, a vessel, especially it tends to be centered on an arteriole, it's a macroaneurysm that ruptured. And the treatment, this is one of the few things there's still not a randomized controlled trial on. I think people are kind of comfortable with treating it. It's like, it's like wearing a parachute when you jump out of a plane. Although I have to say, when I was in training, Mary Lou Lewis, who was a very good medical retina specialist, but unfortunately had her entire career where Dr. Gass was, so people, otherwise you would have heard of her more. She said she never treated a macroaneurysm in her whole career. She goes, I've never lasered one. They always get better. She goes, every time I'm thinking of lasering them, they get better. And there's other faculty I work with who treated every single one. So there's a paper from Wills that I could not find from the mid-'80s where they did a large retrospective review of, I think it was over 100 patients, and looked at which ones self-sealed and which ones didn't. And it seemed like the ones that hemorrhaged self-sealed. So once they've bled, you don't usually need to treat them. If there's subretinal fluid, you probably should treat them. If they're pulsating, that's makes you nervous, and you probably should treat them. And the other thing you can do is you can always do an FA. And if they're leaking on the FA, it means that they're leaking and you can treat them. Treating them is a little tricky. Do I have a slide on that? So this is, so laser, you can either directly laser them, indirectly laser them. I directly laser them. Everybody else indirect. I could tell you the other faculty we work with all indirectly laser them. So what I do is I try to get a 1,000 micron if my laser will do it. Otherwise I do a 500 micron spot. And I turn it really low, down to maybe 100 or 200, and put the duration up to like a second, or continuous even. And then I just sort of whiten it over. I sort of paint over the macroaneurysm. The thing is, you can rupture them when you're treating them. So if you don't set your powers right, you'll pulse it. I can tell you, when you start practice, you'll have a patient where you forget to set your powers. I had one, I remember it. Or I didn't set the spot size or something. There's a lot of things to take care of. You're sitting there getting the lens on, and they're going, you got to keep track of which eye to treat, and then you got to keep track of the lens. So you have to get your spot size, your power, and your duration. And we don't laser much anymore because we use anti-VEGFs all the time. People will use anti-VEGFs for macroaneurysms, which is weird to me. But they'll seal up leaky vessels, but I've not done that. So this is a 90-year-old patient. They're very old patients. The vision in the right eye was down for 6 weeks. She's 8/200. The left eye's 20/50. This is what she looked like. The macroaneurysms can look kind of white. There's a little bit of blood around it, which for me, that sort of goes with not treating. I did a fluorescein. You can see it. It's on the artery. You got to look early. Later, it really doesn't look much different to me. So I figured this one sealed itself up, so I left it alone. And it got better. I don't have a follow-up on her. And then this is an 87-year-old lady. Actually, this I just saw. I'm showing her other eye in the vein occlusion lecture, which we have to get through. And this was her better eye. This has just started happening a couple months ago. She came in with this hemorrhage up there, and it's over that artery that looks really horrible. It's silvery artery, and there's a likely a macroaneurysm in there. The fluorescein doesn't really show it, you know, so, but it's a hourglass hemorrhage, so she got a pre-retinal hemorrhage and a subretinal hemorrhage. So the only thing that really does that is macroaneurysm. So if the fluorescein doesn't show it, you don't need to treat it because it's obscured, so you can't treat it, or it's not leaking. It looks like it. All right, so arterial macroaneurysms are also hypertensive. Now, does any, like for extra credit, there are 2 other diseases that I know of that cause retinal arterial macroaneurysms. This is hard.
Sickle cell.
What's that?
Sickle cell.
No. That's right.
Can't diabetes do it?
Not really. Not arterial macroaneurysms.
Marfan.
No. They're not easy. This is a hard question. This is like a fellowship question. Coates disease, you get retinal arterial macroaneurysms, and then idiopathic retinal vasculitis, aneurysms, and neuroretinitis will get arterial macroaneurysms. So they're mostly all hypertensive. So AV nicking is predictive of high blood pressure. Is that true or false?
Oh,
False. That's not true. It's not predictive. And that's it. So, one question.